Psychiatric History and Mental State Examination, Part 4 of 4. So in the last section, we talked about the mental state examination, and we broke it down into these headings. The headings are appearance and behaviour, speech, and we talked about the rate, the volume, the tone, and the fluency. We talked about the mood and considered the objective mood and the subjective mood. So the objective mood is what the healthcare practitioner feels that patient's mood is like. And the subjective mood is what the patient themselves feel that their mood is like, or how the patient themselves describes their own mood. We talked about the affect, which is the emotional reactivity in the face or the emotional responses seen in their emotional expression. We then talked about thought and split that up into thought form and thought content. Thought form being, put simply, how do they put the sentence together? Does it make sense? If it doesn't make sense, then it may be a thought disorder. And it's important to try and pick out what kind of thought disorder that is. Are they jumping from topic to topic? Are they going round in circles, but eventually get to the right answer? We then talked about thought content, which is what is the patient actually talking about? Are they expressing any delusional beliefs or self-harm thoughts? What are they actually thinking about? We then talked about perception and talked about hallucinations, which can occur in any of the sensory modalities, although auditory and visual hallucinations tend to be the most common. They can also occur in terms of taste hallucinations or tactile hallucinations. We then talked about insight into the mental health problem. Does the patient have good insight? Do they have no insight? It's really a spectrum, and people can lie anywhere along that spectrum. And when somebody lacks insight into their mental health problem, then that may affect their ability to weigh treatment decisions when it comes to treatment decisions about their mental health. And weighing your treatment decisions is one of the key components of assessing capacity. Therefore, a lack of insight may mean that the patient doesn't have capacity. And then we talked about cognition. So cognition is generally assessed grossly. We sort of assess whether the patient can pay attention to what you're saying, whether they're able to concentrate on the things you're saying. However, you can test this more formally by doing a 30-point mini mental state examination or a 10-point abbreviated mental test score. So that's the 30-point MMSE or the 10-point AMTS, which you can easily find online. And these are both screens for cognitive impairment and dementia, but they do have uses in other situations as well. And the final part, which I've put at the end of the mental state examination, is the risk assessment. So we have to think about risk to themselves, risk to other people, and risk from other people. And although I generally document my risk assessment, and most people document their risk assessment at the end of the history taking and the mental state examination, it's really something we do throughout the whole assessment. So in the next part, we're going to watch a YouTube video, which is a video on a patient who presents to his psychiatrist due to concerns from his friend that he may be unwell. And he's presenting with symptoms of mania. Grab a pen and a piece of paper and write down those headings that we talked about on the previous slide. So just go back one slide and make sure you write down those headings and leave some space to write some comments. And what I'll want you to do is watch the video, try to write a comment or a few comments in each of the sections of the mental state examination. Once you've done that, talk in your small groups and see what you've written. Remember, with a mental state examination, the idea is to write it in such a way that you're able to describe what the patient is like to somebody who is not there. So try be specific in your responses and give examples and use verbatim things if possible. To get to the link, I've attached it to this bit here, just underneath the YouTube video. So click on that, and in the next slide, I'm going to give you a model answer. So after you've watched it, after you've written down your comments and discussed them with your peers, we can go through a model answer. Okay, so hopefully you've had a chance to talk through your mental state examination in your small groups. This is a sort of model answer that I've written, and it is very detailed. And because I've had the chance to go over the video a few times, I've been able to write a really thorough mental state examination and pick up on most of the signs that were present. So if we start off with the appearance and behaviour, I'd write something like dressed in a brightly coloured stripy shirt, hair appears slightly untidy, but otherwise appears kempt and clothing appears clean. He appears older than his stated age of 36. He appears distractible and disinhibited and over-familiar with the doctor. And if I wanted to write an example of that, I would say the example of when patient says to Dr. Vedi, "What's your name?" And she says, "I'm Dr. Vedi." And then he says, "No, what's your real name?" Or perhaps I'd use examples of when he swears during the medical consultation. I would say superficial rapport was established between the doctor and the patient. Initially, he was engaging with the assessment, but then he did become irritable towards the end. There was good eye contact throughout, and during the assessment he appeared very animated and restless, or you could use psychomotor agitation or agitated. Moving on to speech, I'd say his speech was very pressured, and pressured speech is basically when someone's talking so much it's really difficult to interrupt them. It's like they've got so much to say and they're very talkative and you can't get your word in. That's what it feels like on the receiving end of hearing someone with pressured speech. It was also quite fast at times and difficult to follow what he was saying exactly. I then moved on to mood and affect. So subjectively, the patient said he felt fantastic. He even said he's the manic mechanic. Objectively, so that's my view of his mood, he appears elated and jovial, or his mood is elevated. Any of these words would be suitable. But I'd also mention that at the end of the assessment, he does become quite irritable. And that is seen in mania. So in mania, don't get the impression that people are always happy and have elevated mood, because irritability is also one of the symptoms. He has expressed some of the mood symptoms, and this would be the right section to put it in. So he said he doesn't need sleep, that he's got loads of energy and his energy levels are high. And in terms of his affect, I've written that his affect appears reactive. Some may say it's slightly labile as well, so it's sort of rapidly shifting. That's what labile affect means. We then moved on to thought, and I believe he's thought disordered, so I've written down some examples. So I think the main thing is he's got flight of ideas, which is a sign of mania. And flight of ideas means he's jumping from topic to topic. So even if you didn't know how to describe or what flight of ideas actually meant, you could just write he's jumping from topic to topic. And if you are able to write things out verbatim, it's a really good way of demonstrating that he has a thought disorder. He's also mentioned a word trick cyclist when she said she was a psychiatrist. And this is a made-up word. It's not a real word. And in psych language, that's called a neologism. Neo means new, and logism is to do with language. So that's a new word he's made up. I think he only made the one word up during that consultation, but if you can imagine somebody making up loads of new words during a patient interaction, it can be really difficult to follow what they're saying or try and understand what they're saying. He's also said some clang associations and used rhyming, which again is one of the signs suggestive of mania. So he said, name's a game, diddly dang, waddly dang, top cat, top man. And these are examples of clang associations and rhyming. In terms of thought content, so this is again, what is he actually talking about? So the themes are very grandiose. His thoughts are very grandiose. And he's got this complex, I'd say grandiose delusional belief about adding up numbers and somehow having the cure for cancer. And he's also very preoccupied and about having the cure for cancer. If I wanted to, I could write in this section that he's sent letters to the Pope and the Archbishop of Canterbury and Tony Blair. In the next section, perception, I've written that he's mentioned God talks to me and says I'm doing a really good job. He did not appear to be overtly responding to any unseen stimuli during that patient interaction. So it would have been a good idea to really explore, when does God talk to you? Was it earlier in the day? Was it 2 minutes ago? Was it a week ago? Was it yesterday? Because a mental state examination is really supposed to be the snapshot at that time. So ideally, you're supposed to only write if they've had that hallucination during that examination or during that interaction. But I've put it in anyway, because he did mention it. The next section is insight. So this is insight into his mental health problem. So this was explored by Dr. Veddy, and he became quite irritable at this point. So it's worth noting that down. He does not recognize he is unwell, and he does not think he has a mental health problem. So from that point of view, he lacks insight, or he doesn't have insight into his mental health problem. And as I mentioned, insight or lack of insight is closely linked to capacity. So if somebody does not have insight into their mental health problem, it becomes impossible or really difficult for them to weigh treatment decisions about their mental health. The next section is cognition. This was not formally assessed during this interaction, but it has been sort of grossly assessed. He appears distractible and has some difficulty with concentrating. So I feel his cognition is impaired, and that may affect his understanding of information. So again, that's something else that I have doubts about, whether he is really able to understand information about his mental health. And the next section is risk. So again, we've got to try and think about it as risk to self, risk to others, risk from others. So in terms of risk to self, we often think about risk of suicide to the self, and we haven't explored that during this patient interaction, but he did not express any thoughts of suicide. The other risks to himself include his vulnerability and risk of deteriorating mental health. Remember, he doesn't have insight into his mental health problem, so it's very unlikely that he would willingly accept treatment because he doesn't believe he has a mental health problem. So that is a risk, because his mental health could deteriorate. There are other risks to self apart from suicide, although often we just focus on the risk of self-harm and suicide. We also do need to think about the risk of deteriorating mental health, the risk of vulnerability, and perhaps the risk from others as well. He appears very unwell and therefore could be at risk of exploitation. I have worked with patients who during manic episodes have taken huge risks with their finances and gambled money away, things they wouldn't normally do. So these are obviously risks to consider as well, because they could be left in huge debts when they come out of this manic episode, or they may end up using drugs and alcohol or driving recklessly under the influence of drugs and alcohol whilst they are manic, because they are feeling invincible. And that itself is a risk as well. They could do something dangerous to themselves or other people. So these are all risks that need to be considered when thinking about how we're going to safely manage this patient and whether this patient can be managed in the community or needs to be managed in a hospital. So in summary, we've talked about in this webinar the psychiatric assessment, and that's the history taking, the mental state examination, and the risk assessment. We've also had a brief practice of a mental state examination, but it would be a good idea to have a look through other videos and try to practice doing a mental state examination. And that's all that you need to do to keep up the skill, is keep on practicing. And I think in your setting, whether you work in the sexual assault referral centres or police custody, there's always going to be some people who have real concerns about their mental health. And for those people, we need to do good psychiatric histories and mental state examinations. The other people I would consider doing a very thorough psychiatric history and mental state examinations are the ones in police custody who have been arrested on a serious indictable offence, such as murder or rape or something very significant, because that assessment could be really useful later on down the line in case the client wants to plead perhaps insanity or wants to say that they were not fit to have an interview at the time or something. A recorded mental state at that time of arrest can be so useful to understanding whether there was a mental health problem or not that was affecting them at that time.